Hi everyone, my name is Gurjat Basra and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. I'm very pleased to welcome you all to today's breakout session on chronic lymphocytic leukemia or small lymphocytic leukemia. Just before we start, I want to go through a few housekeeping items. This Zoom software does not allow you to access chat features or turn on your microphone. So if you do have a question, this session will be followed up by a live Q&A session, so please hold on to your questions and be sure to attend the indolent non-Hodgkin lymphomas and CLL/SLL Q&A after this session. So to introduce our speaker today, we have joining us here Dr. Carolyn Owen, who is an associate professor in the Division of Hematology and Hematological Malignancies at the University of Calgary. She completed internal medicine training in Ottawa, hematology training in Vancouver, followed by a research fellowship in molecular genetics at Barts and the London School of Medicine in London, UK. Her prior research is focused on familial myelodysplasia and acute myeloid leukemia. Her current clinical interests are low-grade lymphoma and chronic lymphocytic leukemia, and she's also the local principal investigator at the Tom Baker Cancer Center for several clinical trials in these areas. So thank you, Dr. Owen, for joining us today, and you can get started as soon as you're ready.
Thank you. Okay. So these are my disclosures. Forgive the fact there's a cat moving through my screen. I know that this is a patient-focused and caregiver-focused presentation, so I really want to keep things very broad in terms of understanding CLL as a disease, with a discussion around who needs treatment and when treatment is appropriate, and then obviously some discussions about the individual treatments themselves. Although I think the nitty-gritty of the individual treatments is probably something better discussed with your physician directly if you were going to be embarking on treatment. So I'm not going to go into all the risks and benefits of each individual therapy. I think the most important thing to understand about chronic lymphocytic leukemia is it's really a lymphoma. And so before we started, I really should have introduced this as both chronic lymphocytic leukemia and small lymphocytic lymphoma, because those two diseases are the same entity. It's just that a leukemia is named because we can see the abnormal cells in the bloodstream. And that's how this disease is most commonly diagnosed. A very rare subgroup of people with CLL actually don't have circulating lymphocytes that we can easily test for or see in the blood. And so those patients have what is called small lymphocytic lymphoma. And if you take out a lymph node from a patient with CLL or a patient with SLL, and you look at them under the microscope and you do all sorts of biological studies, the pathologist cannot tell the difference without the blood work there to show you whether the lymphocytes are there or not. So it's really just a different sort of presentation of the same disease. So for this reason, often when I'm talking to my own patients, I will talk about lymphoma because the CLL is a lymphoma that circulates in the blood. A lot of people hear about leukemia and it sounds a lot more scary because we think about the aggressive disease that affects even young children, and chronic lymphocytic leukemia is not related to that acute leukemia. It is related, though, to other slow-growing non-Hodgkin lymphomas, which is why it's present in that session here in this talk. Also, if you look at the little schema on the side, you can see that the non-differentiated, very immature blood stem cell can either become a myeloid cell, which makes red cells, platelets, and healthy white cells called neutrophils, or it can become a lymphoid cell, which makes lymphocytes. And so acute leukemia affects the sort of left side of that pathway, and then chronic lymphocytic leukemia and lymphomas come from the more right side of the pathway where the lymphocytes exist. And a healthy lymphocyte, its job is to fight infections. And chronic lymphocytic leukemia has this excess of lymphocytes, but those lymphocytes we talk about in pathologic terms are incompetent, which means they don't do a normal lymphocyte job. So a normal lymphocyte, a normal B lymphocyte makes antibodies, helps fight infection. these CLL lymphocytes in the blood, they just do nothing. They float around. They don't make healthy antibodies. They don't really do anything particularly noxious, but they also don't provide any function within the blood system. So who gets CLL? At the end of the day, it's actually quite a common diagnosis. Most people are incidentally detected because of abnormalities in the blood work, because you can pick that up very quickly before any problems derive from the disease. This is actually the most common lymphoma in the Western world, and it's a disease of aging. And so if you're watching this and thinking, I'm not that old, then it can affect younger people as well. Average age of onset is around early 70s. And so most patients don't require treatment right away with this disease. And so the average age of needing treatment is well into the 70s. So that's sort of reflected more recently in the clinical trials of who is included in studies for treating this disease. The other question a lot of people ask is, why me? Or why did this happen? Is there a way that we can say there's something that you did or didn't do that may have increased the risk of this disease? And the answer is it doesn't look like that's the case. The only epidemiological factors associated with CLL are that it's more common as you get older. That just means you're lucky enough to have lived on this earth long enough. It's more common in men than in women, and it's not related to testosterone levels that we can tell. There's ethnicity differences. So actually Caucasian people have a higher incidence than Asian people of this disease, and we don't really know why again. And then there is some familial link. So if people in your family have had CLL, then your chance of CLL is a little bit higher. But there's no clear association with occupations or exposures that we know of. So why is this a disease if some people are diagnosed and they're completely asymptomatic? I mean, you would think that that's not a bad thing if it's something not causing harm. And that's what's really important about chronic lymphocytic leukemia, is there are people for whom this is a disease that causes harm and that needs treatment. But there are actually a group of people with this disease who never actually are harmed by it. And so it's more like a lab variant in some people. So it's quite important to recognize that when the diagnosis is made, most people don't know whether they're in the group of people who actually will be able to live a normal life and not actually be impacted by this, or the kind of people who have this as a disease that will require treatment and that will be now some chronic issue to manage within their medical system. So these CLL cells, as I mentioned, they float around in the bloodstream and they don't really do much of anything. The ones that are in the bloodstream are almost inert. They're sort of not particularly active, so they don't invade things. They don't cause harm. But the cells that are within the lymph nodes or the spleen or the bone marrow, these CLL cells are more active. They're probably getting signals from that environment to be more sort of awake and active. So when CLL cells are growing in the lymph nodes, then the lymph nodes can enlarge and that can be uncomfortable, or the spleen can enlarge, or the bone marrow, the CLL cells can grow within the bone marrow and make it hard for the bone marrow to produce the normal healthy cells. So those are ways in which CLL can affect a person and potentially need treatment. Similarly, CLL, because it is almost replacing some of the healthy lymphocytes, it can get in the way of the healthy immune system. And so some people who don't have a very advanced CLL will still have an increased risk of infections, or everybody will have a slightly increased risk of infections compared to the normal population. But some people will have recurrent infections because of their CLL, and that might be their biggest issue from this disease. So knowing that not everybody needs treatment for this disease ever, or certainly right away, one of the big things that is discussed in clinical appointments and that people are interested in themselves is trying to predict, will I need treatment? Or if I need treatment, will it be now or will it be later? And is there a way to sort of figure that out? And actually, one of the best ways to guesstimate whether you need treatment or if you need it sooner rather than later is just looking at this basic blood test where the lymphocytes are higher than normal and looking at how quickly those lymphocytes increase over time. And that's the lymphocyte doubling time. Now, Just because the lymphocytes are doubling doesn't mean that the disease is bothering people and they need treatment. It just gives you an idea of how quickly things might be slowly changing. And so the cells in the blood usually aren't bothering you, but if you have 12 lymphocytes one year and 14 lymphocytes the next year and 18 lymphocytes the next year, and it takes 5 or 6 or 10 years for the lymphocytes to double, then that is a very, very slow growing CLL. If your CLL has doubling that is occurring with less than 6 months interval, that's considered to be a situation where treatment is probably quite imminently needed. And if it's a year to 2 years, then we'll say it's somewhat intermediate. So there's a diagnosis. You might not know this about your own CLL if you've got CLL, but those two tests are IGHV mutation and deletion 17p. So to talk about deletion 17p, that's a bit of a simpler. It's a problem that can occur within the leukemia cells where they lose a part of the short arm of that chromosome 17. And it contains a very important gene for the cell recognizing injury within its own genetic code. So when the cell recognizes injury in its genetic code, it should say, I don't want to be alive if I've got major genetic problems, and the cell should trigger a automatic cell death process. So if you're missing that gene that recognizes the DNA damage and then the cell doesn't die, then those cells tend to be a bit more aggressive and they tend to be a little less responsive or a lot less responsive to standard chemotherapies, which work by causing DNA damage. So a CLL disease, it's not the person carrying the CLL who has this lack of this chromosome. It's only within the leukemic cells, but that's a problem that can happen over time. So it's something that somebody may have at their first treatment requirement, or they might not have it when they first need treatment, but if they need treatment for a second or third time, they might develop it later on. The IGHV mutation status is a bit more simple in that it is either present or absent in the CLL, and it never changes over the lifetime of the CLL. So if you have CLL, you either have unmutated IGHV CLL or mutated IGHV CLL, and that will never change. The understanding is that normal B cells develop over time from an immature stem cell to a very mature plasma cell, which makes antibodies and is targeted against foreign invaders. So when the cells are immature, they're floating around. If there's an invading antigen within the body of the person, so usually an infection, a bacteria, the B cell sees that bacteria, for example, and it tries to latch onto it to kill it, because that's the job of the B cell. And when it latches on through its B cell receptor. If it joins really well, then that's a positive signal to the body to keep making that kind of B cell. And if it doesn't join well, then the cell just kind of dies. But in the process of deciding if it's going to join well, the B cell mutates its immunoglobulin to make chance changes to the antibody that will make it better fixing to the bacteria and make it a more useful B cell. So developing mutations in the B cell receptor is a normal part of maturation of a healthy B cell. So people whose CLL has mutations in the IGHV means that their CLL, the sort of cancerous cells, has derived from a more mature B cell precursor. And what that means is the more mature the B cell is, the less sort of much it replicates, the less aggressiveness it could have. So aggressive acute leukemias derive from much more undifferentiated cells. And within CLL, the mutated IGHV CLL is typically less fast growing, more responsive to treatment, has longer remissions. And people whose CLL has unmutated IGHV have a slightly faster time to first treatment and often shorter remissions. And there's no changing that. It's just how the disease happened to develop. This is the staging system for CLL, which is completely different from other cancers. And very important to remember that CLL is a blood cancer and it is circulating at diagnosis. So staging is not like a solid tumor where, if you have a lung cancer to start with and it spreads somewhere, then that's, stage 4. With CLL, most people are stage even 0, can be just lymphocytes. Lymphocytes with a few large lymph nodes is RI stage 1. And then if problems start to come, developing large spleen or developing anemia, not enough red cells, or thrombocytopenia, which means not enough platelets, then the staging of the CLL is increased. Now, why do we talk about who needs treatment when this is technically a cancer? And obviously that is the most difficult thought process for people when they first are diagnosed with CLL or when their family member is diagnosed with CLL. The notion that you would be told you have a cancer and that there is not a plan to do something about it is very illogical and often very distressing and upsetting. People feel that they're kind of being abandoned by the medical system or by their doctor because they've been told they have a big problem and yet no one's going to do anything about it. And so it's really important to understand why this is the approach and that there is sort of justification and evidence for this. Because most people, when they're first diagnosed with CLL, actually don't meet our criteria for needing treatment. So most people have to learn to live with the process of active surveillance, or what in the old days was called watch and wait. And this is standard recommended approach from all of the different international guidelines for the management of CLL. And the logic is that in the old days, they actually did a clinical trial, a couple of them, where they treated people right away, or they waited until there was some kind of bother from the disease and only initiated treatment if there was some bother. Now, in the old days, our treatments were not as good, and they were actually potentially more toxic than the current treatments. But in the study of treatment versus watch and wait, the patients who got treatment right away did less well. So it wasn't just that they didn't do better, they did less well. That's one reason, obviously, to defer treatment. The other reason is that within the group of patients who were actively observed or had watch and wait, there was a proportion of patients who never needed treatment at any point in their life. So no treatment is obviously better than treatment if you don't need it. And the desire to save those people from any toxicity or any potential harm from even better tolerated treatments is a really big motivation to not treat people who don't seem to need it when they're first diagnosed. So then the big question is, if I'm being watched or I'm participating in this active observation, when would treatment be indicated? So most guidelines will recommend that a lymphocyte doubling time of less than 6 months is an indication for treatment. I rarely treat people at this situation because some people can still wait another 6, 12, 18 months, even if this situation has occurred. But most commonly, if the lymphocytes are doubling that quickly, it does mean that the disease is awake and active and changing, and delaying treatment is just sort of, you're delaying the inevitable. You're going to need treatment anyways. So most people will talk about what kind of treatments are best, make decisions, and initiate therapy if they see that happening. It's just not an emergency. And so you get a bit of time to be able to, think over what is the best treatment for you. You also have to remember that sometimes if the bone marrow is stressed, cells are in there and it can kind of shoot out a bunch of extra cells that might be a transient thing. So we often see the lymphocytes surge if you get an infection, but then they might come back to where they were. So that's not really a doubling time. Or if somebody has a hip replacement, for example, and there's a bit of blood loss and a stress on the bone marrow after from recovery, you might see a leap in the lymphocytes, but then again, a month later, they go back to where they were. So a lymphocyte doubling time means an unexplained increase that is just from the disease and not from some other situation causing stress on the bone marrow. Other reasons to consider treatment are if you're feeling generally unwell and often having either weight loss or some people will describe sweats of the night. That's actually not very common, sweats of the night, for an indolent lymphoma. That's much more common for an aggressive lymphoma. And even there, most people don't have night sweats. So actually, it's not something that most people need to worry about or think about. But generalized weight loss, again, not super common with CLL unless you have a big spleen or big lymph nodes. But if it was happening for no explained reason, then obviously you'd want to have treatment. The most common reasons that people have a need for treatment or want treatment are that they have lymph nodes that increase in size and are bothersome to them. They can feel big lumps, or that the spleen enlarges and it feels heavy in the belly and maybe squeezes a bit on the stomach and makes it hard to eat. Or that your healthy blood counts, the red blood cells that carry oxygen, give you energy, or the platelets that help you clot, are lower than normal and falling over time because the bone marrow isn't functioning well enough because of the CLL. So the most common reasons for treatment are lymph node enlargement or spleen enlargement that are bothersome, or anemia, or low platelet count. Those are by far the most common reasons for recommending treatment. Even in today's era of much more effective and safe and tolerable treatments than in the really old days when they did the watch and wait studies, we have not yet had a clinical trial that has shown that getting treatment when you are asymptomatic without any of these reasons will improve your survival or general wellness over time. But there are studies that are still ongoing. So it is possible that over the course of your lifetime or my work lifetime, that this might change. But at present, we don't recommend treatment, even for people who have some of the higher risk features, like that unmutated IGHV, or a lymphocyte doubling time that is close to 6 months, or the deletion 17p even. There is currently a clinical trial that is open in some sites in Canada that is enrolling patients who have some higher risk CLL features, but don't otherwise meet treatment criteria, for those patients to be randomized to either be watched carefully or to be started on a fixed duration venetoclax and obinutuzumab. So some of you may be offered that study and can consider it because that's information that will help us decide in the future if that's going to be good for more people. So let's say you actually do need treatment. What kind of treatment are we talking about? So here's some list of drugs that you may have heard of. And if you haven't, then you may hear of them in the future. Traditional chemotherapies are increasingly infrequently used in Canada for CLL and across the world. Fludarabine was the old standard drug, as was chlorambucil. These are traditional chemos that just kind of kill cells that are turning over, but could kill CLL cells as well as some of the healthy bone marrow cells transiently during the therapy. And bendamustine, similarly, another chemotherapy backbone that many people have either had in the past or were receiving until recently. Typically, chemotherapy is given with an antibody. An antibody is a biological drug. It's usually created in a lab. It's like a healthy, normal antibody in the person, but produced to only target one target, and that's the CD20, which is a protein on the surface of the B cell that the CLL wears. And so then it helps kill those cells directly. Rituximab was the original anti-CD20 antibody, and obinutuzumab is a stronger version of an anti-CD20 antibody. And now we have what we call targeted therapies, often still called novel agents, although they're not as novel anymore because they've been around for quite a few years now. And these are targeting different parts of the pathway of that B cell that becomes abnormal in CLL. So the one class is the Bruton's tyrosine kinase inhibitor, or BTK inhibitor, of which there are 3 marketed in Canada now: ibrutinib, acalabrutinib, and zanubrutinib. There's a BCL2 inhibitor, which is a part of the pathway that stops the cell from not dying, kind of like a double negative, so allows the cell to die, and that drug is called venetoclax. And then there's a PI3 kinase delta inhibitor called idelalisib, which is really almost never used, and that's why I have it in italics. This is one of these very complex schemas to show you how the CLL cell kind of is fed signals from the healthy cells within the body to get it to keep growing, or which parts of the cell processes are misaligned or abnormal that made the cells become cancer in the first place, and targets within that sort of process for where these new drugs work. So The CD20 is a molecule on the surface of any B cell, so it's not actually an abnormal part of the CLL cell, but that's what these antibodies target. The BTK is a normal part of the signaling of a B cell, but in CLL it's overactive, and that's why attacking BTK and turning it off in CLL works well to stop the cells from dividing and to help them slowly die. Similarly, PI3 kinase is a similar kind of pathway to BTK. And then, as mentioned, the BCL2 is more a cell survival. It's telling that it allows the cell to die when you turn off blockage of BCL2. The only time when chemo is still contemplated in CLL today, and infrequently so, is when a person is very young and can tolerate quite intensive chemotherapy, and they have no bad risk features from their CLL. So they either have IGHV mutated CLL, and they don't have a deletion 17p, in which case, in the old days, the studies had shown that FCR, which is a very intensive combination of fludarabine, cyclophosphamide, and rituximab, that it looks like some patients could actually potentially be cured by that. So following people out for many years, those who hadn't relapsed by 10 years, it didn't look like relapses were happening. There was an update to this series of patients from the MD Anderson recently, and it reported that of those who looked like they were cured of their CLL, 6.3% of them developed a secondary leukemia process from damage from chemo on the bone marrow, because obviously they live really long after their CLL is cured, but then there's been harm to the bone marrow. So even though FCR may cure CLL or even functionally cure it, give people 20 years of remission, that's, if the disease comes back after that, that's still great. There is still a potential risk of causing a different, even worse problem with the bone marrow later. So most people are still not super keen on this, but it is the only situation in which most people would still discuss the possibility of chemo today. Everybody else will be recommended to receive a novel therapy or a targeted therapy, of which I've mentioned the two classes are BTK inhibitors or the BCL2 inhibitor venetoclax. So I mentioned that there's 3 different kinds of BTK inhibitors, and the first to market was called ibrutinib, and it was life-changing for thousands of patients. It works in people who have failed everything else, who've had chemotherapy multiple times, it isn't working. It is an absolutely excellent, highly effective drug. The problem is that once we started using it a lot, we recognized that it also had quite a few side effects that started to show up with time, of which atrial fibrillation, which is an irregular heart rhythm, bleeding, mild diarrhea, aches and pains, which is really hard to tolerate if you're taking something every day, because the problem with these drugs is that they continue until they stop working. So ideally, if they're working, you start them, you stay on them forever. So that's potentially years. They are tablets, which is very easy. They don't cause a lot of suppression of the healthy blood cells. That's the myelosuppression. This doesn't happen very much. And these drugs are only funded for people who've never had treatment before in some patients, usually those who have considered to have higher risk CLL. Because if your CLL is considered to be good risk and likely to respond really well to any therapy, have good long remissions, then it's very costly to the healthcare system to second to the acalabrutinib and zanubrutinib have both been shown to have less of the bad side effects. So they are the preferred agents over ibrutinib. This is the ibrutinib studies, long-term follow-up for previously untreated patients, just to sort of highlight the fact that if you do stay on a BTK inhibitor, you get it frontline, and you don't have bad side effects, you're a compliant patient, you take it every day as prescribed, it works extremely well. And failures, people progressing while on the drug, which is when you're supposed to stop it, happen very infrequently. Now, this is the data for venetoclax. Now, this drug is even more potent in the short term than the BTK inhibitors. So the advantage to it is it doesn't need to be taken forever. It can be taken for a fixed duration and then stopped. In the frontline setting, that fixed duration is just 1 year. In the relapse setting, the fixed duration is 2 years. It's still oral. It doesn't have almost any side effects except early on, it can cause some lower blood counts while it's happening. And at the very beginning, because it's so potent, if you get too much of it too fast, it can cause an excessive breakdown of cells. So we don't give it too fast. We give it at a really low amount in the first week and slowly increase each week. But then you have to watch with blood tests each week to make sure it's not causing any harm. And because of that, that means that the first few weeks, it's very high effort for the patient and the doctor. You have to do lots of blood tests, and you have to watch all those blood tests, and you have to get lots of phone calls. It's also typically given in combination with one of the antibody drugs, the rituximab in the relapse setting or the obinutuzumab in the frontline setting. And so then obviously the advantage of being oral is somewhat lost because you have to combine it with an IV drug. Venetoclax and obinutuzumab is funded in anybody and everybody for first-line treatment, except currently in many provinces for the fit patients who the provinces would like to think about giving FCR to. But I think that's going to change soon. There's definitely a move towards making this more broadly available for everybody because there is good data for venetoclax and obinutuzumab even in younger fit patients. So pretty soon that would be a good option for everybody, whereas the frontline BTK inhibitor would be in most provinces just restricted to people who have higher risk CLL or somehow are not appropriate for venetoclax and obinutuzumab. And this is the curves showing you how lovely the little bit blurry, sorry, but the advantage of venetoclax and obinutuzumab is over the chemo comparator that was used in this study of sort of older patients with other medical problems. People with good risk CLL, who I said, are not funded in most provinces to receive indefinite BTK inhibitors. With venetoclax and obinutuzumab, we don't even know how long their remission is likely to be, but it looks like it's probably going to be more than 10 years. So you could get 1 year of therapy, stop, and not have to have anything for years after. So I think that most people, when they're explained that, they're willing to suffer the short-term hassle of intravenous drug and lots of blood tests at the beginning if they know that they're going to end up being able to stop and not have to take anything and be healthy for potentially years and years. There's another combination that I'm not going to talk a lot about because it actually hasn't really come to patients in Canada yet, but it's actually combining the BTK inhibitor class with the BCL2 inhibitor class, so ibrutinib plus venetoclax. The difficulty is we kind of stopped giving ibrutinib in Canada because we knew that the acalabrutinib and the zanubrutinib were better tolerated, have less of the heart arrhythmia. And now all of a sudden we can use the combination for a fixed duration of a year. So that's very appealing. But we worry about causing heart problems that we could have avoided if we had the second generation drugs. So this therapy, this combination for a year is becoming available. It's going to be funded across the provinces very soon. I think it may almost be funded already in Quebec, I'm not sure. But most of us don't want to give it to people who we think have a high risk of a heart problem. And that's anybody who's older or has high blood pressure or diabetes or any other heart risk factors. So this is probably something that we would only be talking about with young, fit people who are hoping to avoid having to take a BTK inhibitor indefinitely, for example, if they have access to one as an alternate choice. In the relapse setting, that's what RR means, relapsed and refractory. There's BTK inhibitors, so acalabrutinib, zanubrutinib, you can get easily. You can get venetoclax in combination with rituximab easily. And so most people who get venetoclax and obinutuzumab fixed duration up front will probably get a BTK inhibitor second line. If you're one of the people who goes more than 10 years, then you might want to get venetoclax and rituximab as your relapse so that you could therapy, so you can stop treatment again and be off treatment for a long time again. If you get a BTK inhibitor frontline and you're supposed to stay on it indefinitely until it stops working, if it stops working, well, then you obviously have to try to change to a different class. So those people get venetoclax. If you quit the BTK inhibitor because of side effects, which is actually relatively common, even with the newer drugs, people just kind of get tired of taking something all the time. Some people can go for a few years even before the disease really wakes up and needs retreated. But at that point, you can either decide between an alternate BTK inhibitor or the venetoclax-based therapy. If you get IV frontline, we haven't done that in Canada yet, so we don't have any firsthand experience. Most of the clinical trials would switch to a BTK inhibitor indefinitely in the people who progress after that, but we don't have much good data to support what is the best approach in that situation. All of the studies in the relapse setting actually look at people who've had chemoimmunotherapy or chemotherapy previously. And so we don't have a lot of good data for how well people will do after good targeted therapies frontline, because, well, obviously people are doing really well right now, and there's sort of newer treatments to come to market. Other newer therapies you may have heard about. So I mentioned that we don't really like ibrutinib in combination with venetoclax because we haven't really been giving a lot of ibrutinib anymore. So soon we could consider maybe having access to acalabrutinib and venetoclax. That study brings that therapy forward. There's a zanubrutinib in combination with a different BCL2 inhibitor. So instead of venetoclax, which is the only one we've had so far, that company is also making a new BCL2 inhibitor called sonrotoclax. So maybe that combination might become available with time. Currently, it's available as a clinical trial in several centers across Canada. So you should look for that if you need a new frontline therapy in the next year. There are BTK inhibitors that work in a different way on a different part of the molecule. So that can work even if a traditional BTK inhibitors, the ones we have now, are not working. Then pirtobrutinib or nemtabrutinib can work after ibrutinib, acalabrutinib, or zanubrutinib if they stop working. There's BTK degraders, which is a different way of targeting that enzyme, which look really exciting. Again, clinical trial open at some centers in Canada, including mine. And then CAR T-cell therapy, which a lot of people are very excited about, immunotherapy, altering your own T cells. That is still not quite ready for market in Canada. I can't kind of predict when it might come. We haven't had a lot of clinical trials offered to patients in Canada for that. So that's really sort of still a future, but not quite there yet therapy. So as Gurjot mentioned, there is a Q&A session to come after. So we welcome you all to attend.
Yes, thank you, Dr. Owen, for that informative presentation. This session will be followed by a short break. I encourage you to perhaps take some time to stand up and stretch, think about any questions you may have, explore the various tabs with our patient resources, or you can take some time to complete our conference survey. So after the break, please be sure to attend the Indolent Non-Hodgkin Lymphomas and CLL/SLL Q&A to have your questions addressed. Thank you, everyone, and see you there.